Orchidia Pharmaceutical Industries proudly announces the iUPros can now be stored on the shelf at temperature not exceeding 30 Celsius for the proposed shelf life 2 years. iUPros is now stable with no significant physical or chemical changes at 30 Celsius for the proposed shelf life 2 years. iUPros shows the best tolerability profile across multiple dose prostaglandins analogs. Another product for your glaucoma patients is Travenorm. Travenorm helps more patients achieve desired IOP reductions. Thank you for your time.
Okay. Good evening, everyone. I hope you are all staying safe during these difficult days, and I hope you are all staying warm and dry in this very cold, rainy weather that's been hitting us for the past several hours. Tonight, in the Glaucomatology 2020, we are honored to host two of the pillars of glaucoma surgery in Egypt. These are Professor Tarek Abu Nasr from Benaha University and Professor Ahmed Khalil from the Research Institute of Ophthalmology. Professor Abu Nasr is the owner of the very famous YouTube channel, who is always helping us with his very useful surgical videos relating to glaucoma surgery and other topics. And I hope you are all fans and followers of this YouTube channel and as interested in it as I am personally myself. Professor Khalil, we have the honor of having him as the president of the Egyptian Society of the Glaucomas. Professor Khalil is a very world-renowned author of glaucoma articles, as well as participating in a chapter, actually in a book chapter on glaucoma, and is a very eminent speaker and glaucoma surgeon in Egypt. On behalf of all our attendees, we welcome our two eminent hosts for tonight, and they have already provided us with very thrilling titles. I personally am eager to listen to their presentations. Professor Abu Nasr is going to discuss the topic of trabeculectomy in 2020, and Professor Khalil is going to tell us about a forgotten art in trabeculectomy. So let's not waste much of your valuable time, and let's navigate through the thrilling events of tonight. Professor Abu Nasr, please take the lead, sir. Thank you. Professor Tarek?
Yes?
Please take the lead, sir. You're live and listening.
Can you hear me now?
Sure, sir. Clear and sound.
Okay. Good evening, everybody. Firstly, I would like to thank Orchidia for preparing this webinar, and I hope it will be useful for all of us. And I'm sorry because my pictures doesn't work, so I'm invisible for you, except my voice will be appearing. Our talk today, I'm going to talk about trabeculectomy in 2020. In the first, I want to share these quotes as I found it very useful for the young ophthalmologist.
Can we share screen, sir, please?
Is it not sharing till now?
Not yet, sir, please.
Okay, I will again.
Yes, sir, it's coming up now. Yes, sir. Now we're done.
Okay. Now, can you see it or not?
Yes, sir. Sound and
okay. Okay. I want to share these quotes because I found it very useful for the young ophthalmologist. The first quote is a surgeon is a doctor who can operate and who knows when not to. And the second one is the decisions are more important than incisions. And the only thing better than learning from your mistakes is learning from other people's mistakes. Now we are talking about glaucoma. How large a problem is glaucoma? Yes, this is the large problem in glaucoma like this one. Because it's second leading cause of blindness worldwide, And there are estimated about 60 million people suffering from glaucoma, and around 9 of them who are blind as the result of it. These numbers are set to increase to around 80 million and by 2020, and will reach around 120 million by 2040. And the highest prevalence of the open-angle glaucoma sadly occurs in Africa. It's a early diagnosis of the angle glaucoma depends totally and exclusively upon the skills and experience of the doctor. Glaucoma is slowly progressive disease. Then you have enough time and chance to put a proper management protocol and change it according to the disease progression. According to the Forsman, among patients initially diagnosed with the manifest glaucoma, 15% of them were blind in both eyes. And sadly, another 26% were blind in one eye. And if we want to compare what's happening in USA and here in our country, in USA, the glaucoma patient treatment costs approximately $400 per year. But if this patient becomes blind, it will rise to around $2,800 per year. That's to say 10 times more. In other hand, in Egypt, the cost of the treatment is around 1,600 Egyptian pounds per year. But if this patient becomes blind, what do you think will be the cost? And this is exactly the economic motivation for the proper management of glaucoma in Egypt. So you must take your time to answer these questions before taking care of your patients. The first, does the patient have really glaucoma? Does the patient need treatment or just follow-up? Does the patient need surgical treatment? And lastly, does the patient need second surgical intervention? In glaucoma management, you must think carefully and deeply, or you will sink. What's the difference between glaucoma surgery and cataract surgery? Here is the cataract surgery. Usually it's just one-step procedure, and all the patients, or most of the patients, well informed on what to expect from the operation. Patient confidence is very high, as success rate is well established because surgery has strong repetition. Follow-up time after operation is very short, almost the same procedure with a limited variation, just removal of the lens and insertion of the artificial one. And the results are amazing and encouraging for both the doctor and the patient. Again, glaucoma, in the glaucoma surgery, the patient is not well informed and does not have realistic expectations results of surgery. Surgeon is under pressure to have the same spectacular results of cataract surgery. Patients do not appreciate the complexity of the operation and unavoidable need for ongoing long follow-up. Unrealistic expectations lead to the patient disappointment and the bad repetition of the operation, and sadly for the surgeon also. The glaucoma surgery, rarely it's a one-step surgical procedure. Many surgical alternatives like trabeculectomy, diode laser, non-penetrating, MIGS, and being a multi-interference surgery, second surgical intervention is not the fault of the surgeon or lack of his experience. On the other hand, a successful operation from the first sitting is depending not only on the surgeon experience, but also on many other factors like the patient tissue reaction, the stage of the disease, and the type of the surgery was used. And here is the evidence of the improved success rate after the second surgical intervention. The success rate increased about 65% to the 96% in the second surgical intervention. Now, you must know your target and you must shoot to cure like this young lady, but please don't be like this old man. Trabeculectomy was introduced by Cairns in 1968 and remains the most commonly performed procedure for the surgical management of open-angle glaucoma till now. And this lady, I examined her in the late 2018. This filtering operation was done by our dear professor, late Professor Dr. Osman Youssef in the 1969. And after 40 years, this operation is still functioning. And we can understand why some surgeons a few years ago were not satisfied and happy with the results of the traditional trabeculectomy, but really trabeculectomy 2020 is not the same anymore. So it's better to describe it as a modified trabeculectomy. The trabeculectomy is not just an operation, it's a plan. This plan molded with the multi-steps to reach the attempted goal. It's a long relationship based on trust between the surgeon and the patient, in which the surgeon should provide the patient with the appropriate, or let's say, the information that very beneficial about his operation and what is expected on the long term. And of course, the possibility of the second surgical intervention. On the other hand, the patient must understand at their own level the details of the disease, the surgical strategy, importance of the following instruction, approximate success rate, the possibility of the surgical difficulties and complication. This trabeculectomy plan starts from the preoperative, which it's better to stop certain local drops, glaucoma drops like the prostaglandin, and to apply a mild form of cortisone eye drops like the fluorometholone. And of course, we are trying to modify the trabeculectomy, so we call it modified trabeculectomy. And close follow-up either with a medication or non-surgical procedure like a massage of the filtering bleb, suture lysis, and releasable suture. And the main important issue is the proper and prompt second surgical intervention when needed in the form of needling, subconjunctival medication, and of course the bleb revision. To achieve the best results in treating patients with glaucoma, the patient must be a partner in their own treatment. And here's the strategy of trabeculectomy 2020. First, to ensure a steady flow of aqueous from the anterior chamber to the subconjunctival space. And second, to minimize tissue fibrosis to assure satisfactory aqueous absorption. We'll start with the first one with the steady flow of the aqueous from the anterior chamber. When we define trabeculectomy, we call it T-shaped trabeculectomy. This technique enables the aqueous to reach the tunnel in the deep sclera and go through smoothly and easily with a minimal resistance to achieve and reach the subconjunctival space. This tunnel must extend beyond the scleral flap. Directing aqueous to a tunnel 1 millimeter in diameter will result in a higher rate of drainage unit area compared to that occurs in the traditional trabeculectomy, where the filtration occurs along the whole circumference of the flap, which is around 12 millimeter. So if we drain the extended subscleral tunnel into a lake, if we extend it, and here is the extended scleral tunnel, if we extend it to be a lake-like in this part, it will increase the surface area to enhance absorption, and this may add more success for the operative results. And so we call it in the letter T-shaped trabeculectomy. And here is the examples of the T-shaped trabeculectomy. This is the ordinary flap. Then after, we just make an 1 millimeter incision to make a tunnel in it. And you can dissect very deep in the tunnel. This flap is around the half thickness of the sclera. And then you can make a shape of T in two forms. This form, you just leave a island here and get the T shape from the behind the island, or you get the T shaped without leaving an island in this part. Here is the end of this one. Here is the T-shaped form without leaving an island here. But I prefer this type of the T-shaped trabeculectomy where we can leave an island here to take a stitch in it. And here is the end of the suture, and here is the T-shaped form. And here is the end of the procedure, and here is the T-shaped form of the trap. After ensuring a steady flow, we go to the next step, is to decrease the tissue fibrosis to assure satisfactory aqueous absorption. We have the tissue absorption in two parts. The first one is the subconjunctival space. We want to reduce the fibrosis in this area. And in the second one is the subscleral flap fibrosis in this area going to the subconjunctival space. First, to reduce the subconjunctival fibrosis, we are using the physical barrier like the Ologen or the chemical inhibitors like the subconjunctival injection of the mitomycin, 5-fluorouracil, or anti-VEGF like Avastin. We'll start with the collagen matrix, Ologen. It's a pore structure, encourages the conjunctival fibroblast to grow into the pores of this Ologen material and secrete connective tissue, which is the form of the loose matrix, and this loose connective tissue will reduce scar formation. Now we are using the same technique, but with a slight modification. Here's the T-shaped trabeculectomy. After making the T-shaped, here is the T-shaped. We take a stitch with a slight modification. Instead of taking stitch in this corner, we just go 1 millimeter inside and take the stitch in this island. I make it in a slow motion. The same will done in the second part, and finishing with the trabeculectomy and peripheral iridectomy, and get the next, the second stitch. And here is the scleral bridge-like, hoping that it will help to get the aqueous smoothly to the subconjunctival space. And here's the Ologen with a tongue-like in this part. I make it a tongue-like to push this tongue under the scleral flap, hoping to connect the subconjunctival to the subscleral space. Another application, which is in chemical inhibitors, the mitomycin application. Traditionally, we are using a sponge application of mitomycin, but now we are using the subconjunctival injection in the beginning of the surgery. In the beginning of the surgery, we just inject the mitomycin and push it to get in the upper fornix, and this allows us for precise delivery of the desired amount of the mitomycin. And of course, we are no longer worried about leaving a part of the sponge behind, and it will shorten the operation time for about 2 to 3 minutes for the application of the sponge in the traditional method. And we inject around 10 microgram to 40 microgram of mitomycin, depend on the patient risk character, like the scarring, thickness of the conjunctiva, tenon capsule, and scarring from the previous surgery. Lastly, with the ischemic bleb is also common with the using of mitomycin, and this ischemic bleb will produce the VEGF, and this VEGF will make a new vessels formation and encourage more fibrosis. So if we are using the anti-VEGF Avastin, This Avastin will block the VEGF and may prevent more fibrous tissue formation. And we did it from about 6 years now with a paper, augmentation of subconjunctival Avastin with the mitomycin. And here's the example to inject at the end of the operation with just injection of the subconjunctival with the blunt cannula under the conjunctiva. It's a Avastin. Now we go to the next part with the decrease the subscleral flap fibrosis. And here is the application. We can decrease this part of fibrosis. At this part, we can decrease the fibrosis by either Prolene thread 60 or mattress 10-0 nylon suture, which is invented by Professor Dr. Ahmed Mustafa, or polyester 50. We call it the Cow Hitch knot, or with the version 80, and we call it the bow tie knot. We go first with the physical barrier with the Prolene suture. It's normal, the T-shaped trabeculectomy. We take a Prolene suture and make a knot like. And this knot, this sharp edge can be rounded by applicating a heat and introduce the flap in the tunnel with the knot from one side and the routed part with the other side, and make a stitch in between to secure it in place, hoping that it will help fibrosis and enhance the percolation from subconjunctival space, subscleral space to the subconjunctival space. Another modification done with the Professor Dr. Ahmed Mustafa, which is subscleral flap suture 10-0 silk mattress suture. And another modification, which instead of being horizontal, it can be vertical. Here is the Ahmed suture stitch, but actually this is a case of the non-penetrating knot trabeculectomy, but it's the same principle. We get a stitch crossing under the flap, hoping to elevate the scleral flap and minimize fibrosis subscleral. And here is the suture. It's in the form of mattress suture. This is another suture. Instead of being horizontal, we make it vertical, and also it's a case of non-penetrating deep sclerectomy, but it's the same with trabeculectomy, and hoping that instead of being horizontal, it will be vertical, hoping that the aqueous will filtrate in this direction, which we want this direction more than the horizontal one. Now we go to the Cow Hitch suture. Cow Hitch suture in the form of the traditional flap. I make a just form of this Cow Hitch suture, and here is the flap. We get stitch from this side and make a stitch in the other side, and go again to this side and make a stitch from in the other side, and from out to in, and make a suture inside it. And this is the end of it. The flap will be, this is the horizontal one, and this is one suture from this one under the flap, and the other suture from the other flap, hoping to let this part more or less loose and aiming to permit more aqueous from the under flap to the subconjunctival space. And here's the example of this Cow Hitch ethibond. The drawbacks in this suture is the needle. The needle is too long, but the polyester of the ethibond is lovely in suturing it. It's the same. It's a blue stained, and this is without stain. It's the same as 50 polyester. Hoping this suture, crossing this area and crossing also the upper part of the flap to make a more or less fibrosis in this area and permit more aqueous coming from under the flap, go to the subconjunctival area. And here is the end of the suture, and here is the end of the suture, and taking a knot at the end of it. For surgeons who prefer the T-shaped trabeculectomy, we modified this suture. Instead of being by 50, we go to the 80, non-absorbable, virgin, or polyester 50 according to your choice. And this is the bow tie suture in cases of if we have an extended tunnel like this, which I'm preferring all the time. We get it stitched, but crossing. Instead of being from this part, we get to the other side and make it the same, but crossing. Here's the crossing as the transverse suture. And here is the end of the suture after completing it. And it's like a bow tie in this area. And here is the bow tie, hoping that this area will prevent fibrosis and let the aqueous coming directly from the under the flap to the tunnel to the T-shaped on the other side. Of course, all these must be followed with the tight conjunctival closure, and you must test it if there is a leaking or not. After finishing your procedure, just inject the anterior chamber and see that the filtration subconjunctival is okay and there is no seeping of the fluid from the part of the conjunctiva. Lastly, the upper conjunctiva in the refractory glaucoma is totally messed up with the previous failed operation, cyclodestructive or valves with all this disadvantage and complication. So why don't we apply our new technique, the health in the conjunctiva, and get the advantage of the gravity by doing a lower trabeculectomy. In the upper trabeculectomy, the aqueous has to creep in the great resistance between the sclera and the flap to reach the subconjunctival space, and of course, it's against gravity. So if we do it, we change our mind and make it use of the gravity and do lower trabeculectomy in a healthy conjunctiva like this one. We must not worry about the lower conjunctiva, lower trab, because of course we are not using the mitomycin because we are using gravity instead, and the gravity plays the major role in the success of this surgery. And here's the ugly shapes of the blips in the last few years. And by using this modification, we hope to see this healthy blips instead of the unhealthy blips. Finally, you are free to choose any of the previous modification to improve your surgical results, and you must be confident that complexity is just simplicity multiplied. We must not stop dreaming to be able to invent new surgical techniques for enhancing our results. Our motivation is to help our patient to achieve a better quality of life. When we reach our goal, they can achieve their dreams. Lastly, you must remember that you cannot learn to swim or do surgery by only reading a book or watching a video. Thank you very much.
Thank you very, very much, Professor Manas, for this excellent presentation. And it actually just increased our appetite for very rich discussion. But let's keep that after we listen to our next pillar in glaucoma surgery, Professor Khalil, who is going to discuss the forgotten art of trap. Professor Khalil, please take the lead, sir.
Hello, doctor. Greetings from Orchidia Pharmaceutical Company. I hope you, your family, and all your beloved ones are safe and in good health. Today, I'm going to talk about our latest introductions for your glaucoma patients. Taflopro Single Dose Unit offers better IOP control to reach a target IOP. Taflopro Single Dose Unit reduces IOP significantly in patients with prior prostaglandin monotherapy. Taflopro Single Dose Unit ensures no severe hyperemia experience with other prostaglandins. Another product for your glaucoma patients is Taflopro Plus Single Dose Unit. Taflopro Plus Single Dose Unit provides numerous benefits when compared to non-fixed combinations. Taflopro Plus Single Dose Unit offers extra IOP control up to 22.3% when switching from prostaglandins analogs. Taflopro Plus Single Dose Units offer a better local comfort. Thank you for your time.
Thank you very much, dear Nader. And we continue the session on what you call the gold standard of glaucoma surgery, which is the trabeculectomy. And my talk actually about the basic successful trabeculectomy, which we all hope to perfect for our patients. So the unifying goal of any glaucoma surgery is to lower the intraocular pressure to preserve visual function. We have to find ways for the surgery to have the robustness we seek in intraocular pressure lowering of a penetrating surgery, yet with a high safety profile comparable or can even be better than the non-penetrating surgery. Trabeculectomy with no adjunct. I actually, in the past maybe 20 years, I have used the antifibrotic agents in very few countable cases along the years, and never in as a primary step in any of the glaucoma cases of, yes, our area of the Middle East and with some African patients. So we start from the beginning of the preoperative examination. We have to examine, as everything in medicine and in surgery, preoperatively our patient very well. The assessment of the conjunctiva and periocular tissues is of utmost importance. We have to look for cicatricial disease because the conjunctiva is very important tissue in the glaucoma surgery. So looking into cicatricial disease, dry eye or other cicatricial disease might raise our attention that this surgery might not be suitable for this patient. Similarly, previous incisional surgery. In many instances, you go in for a surgery and then you find in your surgical site a previous surgery which you cannot work over the previous surgery and you have to find another place. So you should not find this site as a surprise when you start your glaucoma surgery. Active inflammation should be looked for because if it is there or if there is any vascularization, then again this negates our plan. Maybe this is a neovascular glaucoma which we missed to diagnose in the beginning. So active inflammation and neovascularization, even tinier than this, should be well looked for before opening the eye for a trabeculectomy. And then any concomitant ocular disease that might interfere in other ways with the glaucoma surgery. So all these factors play a role in our decision making. The optic disc affection, the visual field loss, and how deep is it? The functional ability of the patient. Is this patient able to move around with his eyesight, and how far is he able to? And the rate of disease progression. So again, these four items play a role in our decision. The anesthesia, actually, if I have the choice, which is not there anymore in recent years in the current practice of most hospitals, we all now work actually with retrobulbar anesthesia, but if I have the choice, absolute choice, then I would go for general anesthesia. The issue is that to get away from the conjunctiva, ideally we work on untouched conjunctiva, even by any subconjunctival injection. So the request I do for the anesthesia consultants working with me is, please go as back as possible in your peribulbar as you can, and as less as you can. The surgical exposure, we have to look for an appropriately sized lid speculum, not a speculum that can pressurize the eye or increase or disfigure the eye structure. And then the corneal traction suture, which is the gold standard now for most glaucoma surgeons. And this is the planned glaucoma site we are planning to work on. So what about the conjunctival incision? This is the now for a couple of decades or more, the classic fornix-based conjunctival incision. So this incision is directly over the planned surgical site, the planned site for filtration. My preferred is the limbal-based conjunctival incision. This incision was popularized actually in the 80s and probably even starting in the 90s. It was very little used, but I have went back to this incision because even if fibrous tissue ensues, it is far and away from the mighty part which we depend on the filtration of the aqueous from inside the eye. So the limbal-based conjunctival incision takes much longer time, needs more attention, but it is my preferred choice in glaucoma surgery. This is a picture from the internet on the cystic bleb in the fornix-based conjunctival incision. And this is a patient on whom I worked both eyes. And this is one eye, both are successful, by the way. And this is the cystic bleb, which you can see with limbal-based conjunctival incision. Never the ugly cystic bleb, which is hanging down over the cornea like this in limbal-based conjunctival. So flap architecture, again, is important. Every step we do in the glaucoma surgery, it has to be done with delicacy and with great attention. It has to be uniform thickness, the flap. It has to be thick enough to co-opt with the sutured edge, not to overlap with full thickness sclera when sutured. So the flap is like this. It cannot be like this or tugged here in the sclera. They have just to be co-opted, to be beautifully co-opted. I remember a word by late Professor Ali Mufti, may God bless his soul, that beauty in surgery gets out beauty in results. So actually your care of the tissues of the eye should be very important. Flap design to minimize the vertical and horizontal shearing is again important. And in recent years, I have added actually an angle to the rectangular flap to make it a pentagonal flap, adding more sutures and adding more adjustability of the scleral flap. The location is usually in the superior limbus, unless there is previous surgery or a problem with the superior limbus. And the size of the excised part actually can be anything, but it has to be smaller than the flap, the outer flap. So even a few years ago, it was the Cayless bunch was prevalent, and it was very small. Even a very much smaller than this is good enough for filtration. So a window, small, can work. Very large, it doesn't work because it gets you very close to the fibrous tissue of the outside. So you have to have this barrier on either side of the deep sclerectomy, or deep part of the trabeculectomy. The flat closure, I always aim at tight closure, and I mean, yes, tight closure. If I inject, which I do not do except when combined with cataract surgery, if I inject fluid in the anterior chamber at the end of the surgery, it simply will not go out of the eye through the flap. This is doesn't mean that it is closed, the flap. No, it is closed in this very high pressure, and which is an abnormal environment in the surgery, but afterwards it will be working very well. So again, tight closure of the flap with 4 or 5 sutures. My technique is 5 sutures, is an important step to prevent creeping back of fibrous tissue into the surgical site. So tightening will usually not impede outflow because we are talking about aqueous, about specific gravity similar to water. So it doesn't, some sutures will not impede the outflow but they will probably impede the fibrous tissue getting back into the surgical site. The conjunctival closure is again a continuous mattress suture making tight closure, which is watertight, and you have to respect the layers while you do. I do not excise tenons actually. I try to respect it as much as possible. Some other surgeons might find it in a different way, and we can debate this, but I enclose conjunctiva, tenon, conjunctiva. So one important thing to mention is the importance of the conjunctiva in glaucoma surgery. And I remember a shout from my Japanese professor, Hajime Inumata, on the following post-operative day when he found the conjunctiva of one glaucoma patient very humiliated by one of, actually, he was one of the senior staff, and he was shouted, "What is more important than conjunctiva in glaucoma surgery?" This man was always quiet, but then when the conjunctiva is mutilated in glaucoma surgery, this cannot be actually be tolerated. So use the gentlest instrument you have for managing the conjunctiva. Not the baracare, not even a single tooth, a thin tooth forceps you can use, but it is not the best ideal. The best is a grooved forceps at the tip. This is a video excerpts of the glaucoma technique, the surgical field exposure. Actually, even sometimes I take more than one bite in the cornea to make it, sorry for that, to make a gentler traction on the cornea. And now the cornea is pulled smoothly down. And this is the limbal-based conjunctival incision, maybe 8 to 10 millimeters back from the limbus, if this is feasible. And gentle dissection, again respecting the panels. And you see now it has gone so far anterior, and there is minimal bleeding actually, because respecting the layers of the dissection, whether the conjunctiva or the tenon. And then again, other traction sutures for the conjunctiva. This is time consuming, yes, but it pays back for the result. You see, actually, there is almost no bleeding except in the very periphery of the incision. And this is the pentagonal flap I have. And you can use, of course, even the regular scalpel or the crescent knife. This is up to your preference. So, but I mean, even simple scalpels can do well. Of course, the routine actually is the crescent knife. And then the trabeculectomy part, which is well inside the scleral flap. This is very important. And then opening gently after penetration of the anterior chamber, or opening the anterior chamber with a small, delicate venous scissors. And then making the peripheral iridectomy necessary. The closure, again, as you have seen in the diagram, it is a 5-suture, 5-10-0 sutures. You can tighten as much as you wish. Actually, to not tighten to the extent to make big astigmatic error, it is just tight enough to close the flap well, but not to induce astigmatism. So I'm mentioning this, so I'm avoiding tightness, not to prevent the filtration or no, but to actually to prevent the astigmatism. So again, tightening does not, in this technique, does not play a role in the outflow of the aqueous along the post-operative months. And then closure of the conjunctiva by mattress suture. And this incision is can be barely detectable after a few months. So post-operatively, a story begins. It is not the surgery, and yes, my patient, you can go home. You will live a happy life without glaucoma hazards. No, actually, another story begins. It is actually as important as the surgical steps themselves. Ocular massage can play a very important role in dislodging potential ensuing adhesions in the first postoperative weeks and months. And actually, in many of my cases, I practice this, not in all cases, but in many of the surgical cases. Postoperative workup, unlike many other ocular surgeries, glaucoma surgery is not a once and for all answer to the glaucoma condition. Close monitoring is the first postoperative weeks and months is an integral part of and is as important as the surgical procedure itself. The surgical procedure, 50%, the postoperative course is another 50%. This might entail the need for some form of intervention ranging in spectrum from some adjustment of the postoperative treatment, ocular massage, to various forms of lab revision. So, when paying care to certain details, custom tailored for the surgeon and each surgeon's hands and individual patients, subscleral trabeculectomy can be an effective tool for reducing the intraocular pressure to desired levels with minor and rare intra and postoperative complications. So this is for this presentation, and thank you very much. And we are looking forward to your questions and the tough discussion of Professor Nader.
Professor, thank you very, very much for this very informative and excellent presentation, sir. Really delighted to hear it. So I think our sponsor have something to tell us now. Orchidea Farm. Okay, is Orchidea Farm ready? And if Orchidea Farm is not ready, might we start our question and answers? Proceed with the question and answers. Okay. Now, at the very beginning, of course, we would like to very heartily thank our hosts tonight for these excellent, very informative presentations. And then I would like to stress the fact that I am so eager to ask multitudes of questions. And let's start with the very interesting and I would dare say debatable topic of a T-shaped trabeculectomy is Professor Abu Nasr. And I would like to ask a very interesting question, which comes as well from the audience, is what would be the difference between a T trabeculectomy and a deep sclerectomy? We know, of course, that conceptual-wise, the deep sclerectomy is about creating a trabeculodesmate window that filters the aqueous humor without penetrating the anterior chamber. For this is a well-documented difference, of course, between a penetrating trap and an unpenetrating trap. But in essence, when we, or let's say theoretically, if we dissect a T-shaped tunnel underneath the scleral flap, we're actually short-circuiting the pressure controlling effect or the trap door effect of the scleral flap on the filter. So does this by any means increase? And the first question would be, what would be the role of the superficial flap in pressure control? In other words, does tight closure of the superficial flap then affect the quality of the filter in T-shaped trabeculectomy, if I may reformulate the question? And having mentioned so, is there a risk of a shallow anterior chamber, or overfiltration with all the sequelae of hypotony, with all the sequelae of overfiltration? I mean, hypotony, choroidals, and so we would very much like to hear the comment of Professor Abu Nasr about these questions. Professor Tara, are you with us, sir?
Yes, please.
So let's reformulate. The first question would be the difference between a T-shaped trabeculectomy and a deep sclerectomy. Would the tight closure of the superficial flap really affect the pressure control, given that the T-shaped is actually, now the tunnel is not opposed to the superficial flap? And the continuation of the question is the risk of overfiltration with hypotony, choroidals, and things like that. Your comments, sir, please.
Well, I think the scleral flap must be very tight. I'm just hoping that the aqueous will travel through this tunnel 1 millimeter in diameter. And I don't like any sweepage of the aqueous all over the flap. So tight suture, especially the suture near the cornea, because we are afraid about this seepage coming from the anterior chamber to the near to the cornea, and getting out through the conjunctival suture.
So it's not only one suture in the. So it's not only one suture in the angle.
No. I'm using at least four. No, I'm using at least four sutures. Four sutures. I'm aiming to the tight suture to get the flap very tight. I'm hoping that the aqueous will just follow with the pressure in the part which is 1 millimeter in diameter, so it get more force and get less resistance in this part of it. So the suture of the flap is very, very important. I would like the aqueous coming just to the lake in the form of the T-shaped, which is very far away behind in the sclera.
Okay. Would you choose, sir, then that the fistula through the anterior chamber be smaller in size than a conventional or a traditional or a pre-2020 trabeculectomy, or you would make a traditional sized fistula that would be maybe a little bit bigger than the standard one? I mean, do you decrease the size of the fistula?
Many researchers come to this point about the size of the fistula. The size of the fistula, 0.75 millimeter, that's quite enough.
No, I mean, with T trabeculectomy, there's no difference, sir.
No, just smaller. It doesn't matter to me the size of this fistula anymore, because 0.75 millimeter is quite enough for me. And this small size fistula will give us the chance to make a very small peripheral iridectomy, not a wide peripheral iridectomy, because if you are making a huge size trabeculectomy, you must get a huge size of the iris, because you are afraid about clogging of the iris in this fistula.
Sure.
And I think that peripheral iridectomy, it's ideal to make it a horizontal manner to get the pillars of the iris not entangling in the wounds of the fistula.
Sure. What about the risk of or the instance of hypotony, sir, with this T-shaped trabeculectomy, sir?
Well, actually, I'm never see one case with the hypotony, because I'm very, very tight suture, and I'm not using a mitomycin sponge or something like that. I'm using the subconjunctival suture, not anymore with the traditional sponge of it. And not with
the subconjunctival injection?
Conjunctival corneal suture, I'm caring about too much, caring about the seepage in this at the end of the operation, that there is no seepage of the aqueous through the corneal conjunctival suture.
Okay, so when we use a T-shaped trabeculectomy, you don't use an anti-metabolite or an anti-VEGF, sir?
No, I'm using the mitomycin in the form of the subconjunctival.
Subconjunctival with the T-shaped trabeculectomy.
Yes. I'm stopped using with the sponge anymore.
Okay. Now this technique, now we're creating almost 2 scleral flaps. So have you applied this technique, sir, in juveniles or in congenital glaucoma, because it's a very interesting issue?
Yes, I'm using this technique in all cases of cases needs trabeculectomy, either in the adult or in the children.
Great,
but the children, I'm more or less I'm using with it the trabeculectomy with the trabeculectomy. With the T-shaped, I'm using a trabeculectomy with it.
Okay. Would there be any length for the vertical arm of the T that you would recommend, sir? 4 millimeters, 3 millimeters? Any recommendations about dimensions?
No. Just the tunnel must exceed the flap, and the flap I'm nearly 4 times 3 millimeter or 4 times 4 millimeters, not more than that.
Now, we are honored, of course, sir, to have you as our mentor, and we know that you are and that you have and still is mentoring a lot of students. So, in your opinion, sir, this T-shaped trabeculectomy, is it an art for highly educated and trained glaucoma surgeons, or could you rely on beginners to do it?
Let me say clearly that in the first step, it's hard to do it. But after sometimes when you are using the scleral dissection, you can use it very simply to use the first step with this, which is the scleral flap, then go to inner tunnel. I think in the first 3 to 4, not more than 4 times, it will be more or less tricky. But after that, I think it's a normal person, normal experienced surgeon can do it very easily.
Okay.
It's a very, very little learning curve. It doesn't need a more learning curve.
Sure. Now, if we're going back again to hypotony, sir, I need to ask, let's say post-operatively, for some reason, there is some sort of hypotony or overfiltration. Now, we know that, for example, in a conventional trab, we would put a torpedo patch, we would put a pressure patch, we would wait to decrease steroids. But in this situation, there is actually, let's say, no tissue underneath the flap, and that is filtering to the conjunctiva. So just in the remote possibility that some other surgeon would face hypotony post-operatively, are there any specific recommendations other than the usual maneuvers for a routine trabeculectomy for post-operative hypotony in a T-shaped trabeculectomy?
Yes, I think, but I have no experience in it because I don't have any single case of hypotony.
Single case of hypotony.
No, not yet. But in the few years before that technique, I have to use the hyaline, subconjunctival hyaline, and the anterior chamber injection of hyaline from the paracentesis side.
Okay. Now,
if I have a hypotony, I inject hyaline in both sides, subconjunctival and in the anterior chamber.
Okay. Now let's move on from the T-shaped trabeculectomy to move to the very, again, rather very interesting issue that you've mentioned, Professor, which is the inferior trab. Let me ask it first from a surgeon perspective. What about the position of the surgeon during the operation, the ease of the procedure, the technicalities of the surgeon location? And the next logic question that myself and the audience are asking, isn't there any risk of increased risk of infection with an inferior bleb? So
I'm using the inferior trab for more than 2 years now, and I did around 28 cases inferior trab because of the upper part of the conjunctiva, which have no space for either tube or another trap. And I'm not using mitomycin at all or any antimetabolites in the lower part. And I have never seen an infection, but I never do it in the children, really.
Okay.
But I have the success rate amazing, more than 85% without anything except massage. The gravity is amazing, really. The gravity is amazing in this part of it. But I'm not using any mitomycin, so I'm not afraid about infection. And this is nightmare of if you have any bleb in this lower part, it will cause infection because stagnation of the fluid.
That's the issue, actually.
No, I didn't met anything of that.
Thank God. For the actual surgery, sir, do you change your position and you sit beside the patient?
No, it's the same. No, it's the same position. Routine. Yes, it's a usual and routine. Really, it's not uncomfortable if you try it. It's a slight change in your technique, but it's not uncomfortable.
Okay, an inferior traction suture, globso production rather than introduction.
Yes, inferior traction
then you operate
suture,
in the usual way.
Yes, okay. It's a usual manner, yeah.
Another thing, sir, about the bleb. I mean, the lower fornix, the globe is opposed to the lower lid. In the upper lid, the lid is opposing the upper 1 to 2 millimeters of the cornea. So the upper conjunctiva has somewhat a potential space to develop a bleb. But in the inferior one, in the inferior fornix, I mean, the lower lid, is opposed to the globe. It doesn't appear to me that there's much of a space for the presence of a bleb. So apart from the surgery being successful, is the morphology of an inferior bleb comparable to that of a superior bleb, irrespective of using mitomycin or not? I'm not speaking about that. But the morphology, because the space that it is developing in is different from that the space of the upper of a superior bleb would be developing in. So any comments about the shape of the bleb, sir?
Yes, it's in the lower bleb, amazing. It's not erased anymore. It's just very, very shallow filtration and very shallow bleb and diffuse and very healthy. It's cosmetically, I don't think it's bothered me too much because the refractory
doesn't push the lower lid.
Yes, and the number of the procedures with the patients going through it all the years before, can forgive any discomfort or any change in the morphology of the lower lid. If it's functioning and the patient is satisfied and the doctor is satisfied with the lowering of the intraocular pressure, because the filtering blip really, it's amazing, better than the upper part. It's a diffuse, very shallow, and very healthy.
Okay, but of course, sir, you would not recommend it as a primary procedure.
No, of course, no.
No, in case of a scarred.
Till now, I'm not recommended to do it in any case. I'm obliged to do it in the lower part.
Okay, when we are obliged, when we are forced, when we're cornered.
Yes, of course.
When
we are forced, obliged. No, I'm not yet. I have no courage to begin with the primary cases in the lower part.
Okay, agreed, sir. Of course, we have to stress to our audience that trabeculectomy is one of the surgeries that has the greatest variability in the technique among different surgeons. It's very difficult to find two surgeons performing trabeculectomy with exactly the same photocopy type of technique. It's a highly variable procedure among surgeons. So that is why we stress the importance that all trainees have to master a certain technique, focus in it, be dedicated to it, and try to minimize the variation of the technique in order to develop a learning curve. When they do have a significant rate of surgeries and cases and significant experience as well, then they would be then allowed to modify and try several things. So I think we need to stress that.
I want to invite you just to try just once the bow tie suture.
It looks marvelous, sir.
Fantastic.
Definitely.
It's fantastic. Definitely. It's really fantastic. And with the 80, not with the Ethibond. Ethibond, it's too more or less, it's a very thick, but with the Virgin 80, the bow tie, it's a fantastic, and you get a very marvelous results with it.
Excellent. Okay, so Professor Nas, please stay tuned with us. We'll just take a short break to address Professor Khalil with just a few questions.
Okay.
Professor Khalil, I would just like to ask a very small detail about the location of the surgery. You've mentioned, sir, that you do it superior. Just a simple question, since you do take a limbal-based conjunctival flap, so the incision is in the fornix. If we're dead superior, and we go far posterior, there's the superior rectus. So my simple question is it dead superior, 12 o'clock, or you might recommend supratemporal, supranasal, just to avoid the superior rectus and the anterior ciliaries? I know it's a simple issue, but it's really intriguing to meet the location of the surgery. So what's your comment, sir, about that? Unmute, sir, please.
Sorry for that. I cannot hear you, dear Nader.
I want to stress section based flap. So sometimes, sir, dissection of the scleral flap results in a bad dissection. Sometimes the flap is torn, sometimes the flap is cut. If I'm making, are you hearing me, sir?
Yes. Now here again. Yes.
If I'm making a traditional, or let's say, I'm sorry, not traditional, let's say if I'm making my incision at the limbus, I can close that incision, reopen at another side. How can I manage if I'm making an incision in the fornix? I mean, so the question would be plain or simple. If for some reason the surgeon damages the scleral flap, the partial thickness, the superficial scleral flap, is there a way out in case in the way?
The sound is interrupted, but if I can get you well, you need to move to another area and make another superficial scleral flap. Is this the question? I mean, yes, I will just a little widen the conjunctival incision. I have so much flexibility and safety in doing this. And I'm very peaceful with this. So I just widen the conjunctival incision a little bit and move the superficial scleral flap in this way.
Okay, so another two issues, Professor Khalil. To start with, since we start the conjunctival incision far posteriorly, do you believe, sir, in conjunctival hydrodissection prior to opening the conjunctiva? hydrodissection of the conjunctiva?
Yes, I would go for sharp dissection because we have anatomical layers which we know from our anatomy books, and if we respect this, I would rather prefer to do a sharp dissection, the subconjunctival tissue, the subconjunctival space, and then we incise the tenon, and then we go in the subtenon space. And as you have seen in the movie, this is very typical. You do not have bleeding, you do not have much disfiguring during this if you go just with an organized, well-informed dissection or sharp dissection. So hydrodissection probably will not be as we do with the sharp dissection. On the contrary, actually, this is why one of the reasons I do not like the anesthesia, the peribulbar anesthesia, to come close from the side, because it make a rather irregular subconjunctival dissection.
Sure, okay.
So again, a sharp dissection is preferred in my hands.
Okay. Now, you've stressed, sir, upon the fact that you need to perform tight closure of the scleral flap and no filtration at the end of the surgery, and you massage post-operatively.
Yes.
We need to stress that to the audience. Okay. So, do you use, sir, releasable sutures, or the 5 sutures are regular sutures and you rely on massage?
No, regular sutures. My theoretical point, my theoretical and subsequently practical point is that you are talking about aqueous, which have a very specific gravity similar to that of water. So, I mean, it would pass easily between sutures in the normal intraocular pressure range of 10 to 25 to 30. I mean, if this is, of course, if you overhydrate the eye, probably fluid will not pass. So, this is a physical issue. The point is that fibrous tissue, you would like to prevent the fibrous tissue from going underneath the flap. So tight closure helps in this. So I do not make releasable sutures. I make very regular tight sutures, interrupted sutures.
Okay. Now, when we close the conjunctiva, sir, let's say 2 issues actually. What happens if an inexperienced surgeon for some reason damages the conjunctiva, buttonholes or whatever? This is an issue, especially if they're doing the blunt dissection towards the limbus. Let's say some mishap happened and there's a buttonhole that is closer to the limbus rather than to the incision site. That's the first question. And with it, let's say during closure, you've demonstrated, sir, excellent, of course, in the video. But my question is, let's say in the hands of a beginner or an inexperienced surgeon, would the globe hypotony at the end of the procedure, would it affect the ease or the quality of the conjunctival closure? Being away from the limbus, the hypotony that is present. I mean, we've opened the fistula, we've done a filtering surgery, although we've closed it tightly, but the globe is still now, let's say it's a neat rupture globe. In other words, it's a neat repaired rupture globe. So the globe is somewhat hypotenuse. The closure of the conjunctiva at a distance from the limb, does this represent any difficulty? So a buttonhole and ease of closure with hypotony, to sum up.
So I start from the second question. Actually, there is no hypotony. Please. This is a very smart question, dear Nader. This is a very smart question, but there is no hypotony at the end. Because these tight sutures, when you are closing the 4th and 5th sutures, you already have a very well-formed anterior chamber, and digitally the globe is very well-formed. So there is no hypotony.
Pressurize the globe.
By the yes, but self-pressurized.
Okay.
I never inject, or I usually, not never, but it's near never actually. I almost never inject any saline or any fluid into the anterior chamber. So it is self-repressurization of the globe. So the globe is not soft. This is one point. So, and the globe is still actually pushed down by the corneal sutures. So there is no issue in closing the conjunctiva as much as the palpebral fissure is open, and this is not a blepharophimotic patient or so. Sure. And no problem in the anatomy. For the buttonholes, this depends on case by case. The buttonholes, of course, you meet these in cases which have been on very long duration of medical therapy. In these patients, the conjunctiva is much friable, and they just sometimes even I refrain from taking conjunctival traction sutures you have seen in the video recording. I just pull in these cases who have been 10, 20 years on medical therapy. I just pull the conjunctiva down over the cornea and it stays there because it is so thin and I can say atrophic, and in these cases buttonholes is rather common. If it is a small hole, or if it is a hole, I mean, I can suture with an 8-0, and I prefer the vicryl sutures. I see them as or the polyglactine sutures. They are gentler than the monofilament, but even the monofilament probably would work. So I close the buttonhole. Sometimes the hole is tiny, or I feel that if I close the hole by the cutting edge of the needle, the hole would widen. And in these cases, actually, I just leave some buttonholes. I just leave them as they are in order to avoid bigger damage. And then I cover the eye for maybe a day more or so. And usually they epithelialize within a few days, and there is no issue with that. But I'm talking about tiny holes. Big buttonholes, then we will talk about conjunctivoplasty and bringing a conjunctival flap from other areas. I rarely meet this actually. So again, a tiny hole, you can, if you feel that, because you put the suture, you put the needle, and the needle will make even more trauma to this very atrophic conjunctiva. So for small holes, if you just leave, I think it will be safe with few days bandage.
Sure. Now we've discussed the art of trabeculectomy, generally speaking. Now we'll need to listen to the comments of our hosts about the application of the techniques to different types of glaucoma. Let's say pseudoexfoliation, neovascular glaucoma. We need to, of course, the question is simply not does it work or it doesn't work. That's a simple issue, definitely. But we need to know, does it work or does it not work? That's an issue. And let's say a specific comment or a recommendation from an expert in specific types of glaucomas using the techniques. So let's start with our dear Professor Ahmed. Your opinion, your comment, sir, please.
Well, I think the only difference in the application of the antimetabolites in the neovascular glaucoma or refractory glaucoma or recurrent glaucomas, I'm using a concentrated mitomycin more than usually I'm using. And at the end, I'm using the Avastin in these cases all the time. But the main issue is the concentration of the mitomycin. I'm using the high concentration and more or less longer time than that.
But the surgical technique
teninectomy is a must in these cases.
Teninectomy is a must.
Yes, yes.
You're not afraid then, sir, of a cystic bleb or?
No, at all. I'm thinking all the time to drop the intraocular pressure by any means because I'm desperate in these cases. Usually I'm operating in this case in late stages in one-eye cases. Most of my cases now it's a one-eyed, so I'm targeting to get the intraocular pressure low by any means.
Okay. May I stress to our audience, sir, that Professor Abu Nasr is usually handling the extremely difficult cases that are likely to fail filtering surgery, and the cases in which the very delicate balance between inducing or lowering the intraocular pressure and keeping the eye safe is a very big issue. I deduce from my work that is why the concern mainly is the safety with the fibrosis that may occur post-operatively. Do I get the message?
I totally agree with you, Dr. Ahmed. Really, Dr. Nader, yes, I'm frankly, I'm dealing with a
complicated refractory cases.
Very advanced cases. So don't take my words for the primary cases, because in a primary cases, I'm usually not just subconjunctival mitomycin, very simple without teninectomy. If I want to do teninectomy, just a simple trick I'm using it. I'm just putting the scissor behind the conjunctiva and see it. If it's I can see it clearly. There is a very few tenon, and there's no need to get a teninectomy. Okay. If I'm not seeing clearly, so it's a more or less tough tenon. So I'm thinking to get some of this tenon in this area.
Does this tenon creep into the tunnel in the T-shaped trabeculectomy, sir? If you open it, I
never see it before. I never see a tenon inside the tunnel.
Okay, so the tunnel remains patent.
In the recurrent cases, just 5 cases, I'm not seeing any fibrous tissue. But I saw a fibrous tissue entering to the Ahmed valve, and I will send it to you in your email. It's a very tough fibrous tissue entering to the valve of the Ahmed valve.
Okay. Now, thank you very much, Professor Khalil. I'm very, very eager, of course, to hear your comments, sir. Please.
No, actually, this is just on the last question you asked to Dr. Tariq. Tenon does not creep back. Fibrous tissue may creep back, but tenon does not creep back. Tenon actually regresses. So this is the tenon is some
the technique
thing which we can discuss for long hours. And the technique is actually, I mean, for example, neovascular glaucoma, then I'll do all the necessary steps to reduce the revascularizations, but then the surgical technique would probably be rather similar in all cases in secondary glaucomas. I can reduce the incision, make it smaller, make the opening smaller, the trabeculectomy itself, the iridectomy, I think about it. But generally speaking, it is the same technique after making the necessary preparation for each particular case.
Would you not consider then using anti-metabolite also here, sir? Or you may consider?
I only use anti-metabolites in recurrent pseudophakic or aphakic glaucoma surgeries. And again, recurrent, or if the pseudophakic glaucoma is not touched in glaucoma-wise, no glaucoma procedure have been done before, probably I wouldn't use. I will consider. But in recurrent glaucoma cases with aphakic or pseudophakic eyes, I do use a mild dose of mitomycin C, which is 0.2 actually for 2 minutes or even shorter.
Dr. David, may I add something, please? It's a very small tricks in dealing with the conjunctiva, because it's very important, the conjunctiva and tenon. Just using a cold saline instead of the ordinary room temperature saline. Put it in the refrigerator for half an hour before the surgery. It's a marvelous step to ensure that you are not using too much cautery to stop bleeding in the conjunctival site or the scleral site you are dealing with. It's a very simple trick, and it's a great increase in minimizing the cauterization, and of course it will minimize the fibrous tissue fibroblast formation in the first 3 to 4 days after surgery. And the cortisone before the cortisone eye drops before surgery also, it's marvelous for it.
Okay, and the coldness does not affect the viability of the tissues intraoperative during the surgery?
No, nothing. It's anesthetic. It's likely it's anesthetic also. It's not so cold that it's not a temperature. It's just 3 to 4 degrees below the room temperature. It's causing vasoconstriction, because if you are using a phenylephrine or something like that, it will cause pupil dilator and will disturbing all the other tissue in the iris. But the cold saline, it will get you a better results in it.
Yes, and on another note, Bardo, to add to the cautery, this is a nice trick to hear.
And by this,
yes, actually, no, just a small comment to add, Dr. Tariq, cautery, excessive cautery is one of the steps that one would like to avoid by all means, either in the conjunctiva or in the episclera.
Yes.
Yes, so I mean, we are talking about beautiful incision, beautiful dissection, etc. Even if you do it in the episclera, this is, if I have to do it with a strong bleeder, for example, a penetrating episcleral vein or aqueous vein, and then I have to do strong cautery in some cases. Actually, the best is just to wait for some minutes, long minutes, in order for the tissues to come back to near normal. Otherwise, all the incisions and all the steps will not be as we wish for. So, yes, we agree on this.
Okay.
Very well.
Sure. Okay, I guess we're running late, and if we continue discussing with our hosts, we would exhaust them and we would exhaust our audience. So unfortunately and very sadly, we'll have to conclude this very, very interesting for myself and I hope for the audience discussion with our marvelous hosts. In the name of all our attendees and our guests, we would like to heartily, very heartily thank our hosts, Professor Tara Abu Nasr and Professor Ahmed Khalil, for these excellent talks and presentations and for sharing with us their vast knowledge and experience about glaucoma surgery. Thank you very, very much. And for all our audience, thank you very, very much. Apologize for keeping you late. Please stay safe and stay warm and good night. Thank you very much.
Thank you, Dr. Ahmed. Thank you very much, Dr. Nader, for this.
Thank you very much.
Thank you for joining, Dr. Tariq. It was a real honor to have you in this session, Dr. Tariq.
It's an honor for me, Dr. Ahmed. Thank you very much. Thank you, Dr. Nader.
Thank you for joining.
Thank you, sir. Most welcome, sir.
Good night.
Thank you.